Hi R1s, it's Dr. Daniels here. I wanted to put this video together to help those of you who maybe are a bit behind on your EPAs get back on track. We've come through Christmas and New Year's, it's 2018, and I'm sure all of your New Year's resolutions were, I'm going to get these EPAs done. Now, we got 6 months, which I think is plenty of time for the foundation stage, as this one's all about being a ward junior, which is probably a lot of what you're going to do in the next 6 months. And as I was thinking about how I could best help you all, it dawned on me that if Foundations of Discipline is about being a ward junior, what if we looked at this as the patient's journey through the hospital and how that lines up with the EPAs? So I hope that you'll find this video helpful. Two things I want to say before I begin. First, I was able to find this PowerPoint template online through a YouTube channel, PowerPoint School or something like that. So I wanted to give it credit because it's quite a slick template. But the second thing is, if at times you hear some thumping or possibly kids screaming, that would be my kids upstairs, probably most likely my 3-year-old, who when I said, please don't jump up and down and scream, he took that to mean I should jump up and down and scream because daddy's recording a video. So I apologize in advance for that. Okay, let's get to it. So a patient's journey through the hospital begins with that initial admission. And this is what FD1 is all about. It's the common acute medical presentations we see in the emerge department. Or if, say, you have a senior who's already admitted them and they're upstairs on the ward, you're continuing that admission and doing a more thorough history and physical and making your own investigation and management plans. Now you need 10 successful observations for this, and 5 of these have to be what's called direct observation. But let me explain what direct observation means. In the Royal College language, direct observation means that the staff, subspecialty fellow, or senior resident just confirmed some of the key features of the case. They didn't watch you do the entire consult admission. The idea is if you've admitted a patient with heart failure, they maybe confirmed with the patient they're more short of breath with orthopnea, they looked at the JVP, they looked at the x-ray and saw interstitial edema. And to be honest, this is probably due the majority of the time. I don't think it's common that an attending just completely takes an R1's word for it. Okay, so probably most of your observations will be direct observation. If, however, it's a case where it's just a very quick review and the attending's just taking your word for it, and they may do that if they've worked with you for several days and seem they can trust you, then that would be indirect observation. As you can see here, for FD1, you need 3 from a staff physician, but the others can be by subspecialty fellows or senior residents. Next, we have the goals of care discussion. You'll notice this is FD6, but I'm presenting this early in the timeline because it should be earlier in a patient's journey. One of the key things to realize is this is not the really complex goals of care discussion where you're changing from R to M level of care or M to C. This is really just about confirming they understand their goals of care and that it's consistent with what's been previously discussed and, asking about their personal directive, all that kind of stuff. You only need 3 successful. These are all direct observations, okay? Not reviewing with the staff I had this conversation. 2 need to be by an attending physician and 1 from a subspecialty fellow or senior resident. 1 also needs to be with a substitute decision maker. So if the patient is confused, which, may happen in general medicine occasionally, then you're going to be talking to, say, a family member. And in that case, that's what they're looking for, is that you can also have this conversation with the substitute decision maker. So that's the goals of care discussion. Now let's say the patient's admitted up on the ward and you're doing your daily rounds. Now the Royal College has divided this EPA FD2 into 3 different aspects. The first is managing the actual medical problems. Now you need 8 successful, and this is really kind of both direct and indirect, but these ones it's sort of okay that it's a bit more indirect. And I don't think there's actually a requirement according to the Royal College documents. But keep in mind there's 8 different categories they want you to have seen. Think of these as 8 different conditions you should see. And really you need 1 successful from each of the categories. Now that's not to say you should just look and wait to get the next one. Still document these because we want you guys to be documenting these at least once a week. But realize with this one, you do need 6 different assessors. So this is not something you're going to be able to bang off in, say, your last 4 weeks, because you do need 6 different assessors. Now, moving on, FD2B is about communicating with the patient and family what's been going on in hospital. And again, this is something we should be doing, but also we probably don't do as good of a job observing our junior residents have these discussions with the patient and family. You only need 2 successful direct observations of this conversation, again by staff, subspecialty fellow, or senior resident. There doesn't appear to be a specific requirement as who the observer is. Finally, the last part of FD2 is about handover. And reading the Royal College documents, the way I kind of understand it is, this is not the same as FD1 where you've done a full consult and you're reviewing the full story. This is more the key features that need to be handed over. So if, say, you did an admission, but you're handing over to another team, and so you're going to give them just a really short story and here are the key elements. Or if you think about your sign-out rounds at the end of the day for services that do that, if you have another on-call junior and you just want them to know, yeah, about my patient, here's what you need to know and here's what I anticipate happening tonight if they run into trouble. So it's that element of it, okay? 3 successful observations, 2 observed by staff. So in the care of a patient in hospital, we often consult specialists in allied health. And this is the one EPA that actually has an ambulatory component, but I'll come back to that in a bit. So FD3, consulting others, you need 4 successful, and it's kind of prescriptive who the 4 are. 2 are observed by the attending physician, 1 by an allied health, and 1 by the physician whom you are consulting. So if you think about it, the reason for that is this EPA is all about, can you ask a good focused question that's understandable to the receiver, okay? So if you are on service with me and you want to consult ID, you should say, actually, Dr. Daniels, can I actually make the phone call? I need to get this one where I actually make the phone call and see if they understood what I said. Say, sure, go for it. So you make the phone call as well as you write up a consult sheet. And then after the consult is done, you can just talk to the consulting team. You know, how was my request of you? My question to you, was it clear? Do you mind filling this out? And I know it sounds like a little bit of busy work, as does all of competency-based. But again, it's getting at the point that unless we explicitly ask for this feedback, we may never get this feedback, how good of a question we asked. So that's what that one's about. Same with allied health. It's not just saying PT/OT, right? Having a very clear question, asking your occupational therapist, you know, I've talked to the family and I think there's some concerns about functioning at home, and it sounds like it predates the delirium. So I was wondering if you could see to offer some input on what we can do to help this patient's functioning. That's a very clear question to an occupational therapist. I think they would be quite pleased to then fill out the form to give you some feedback on that. Okay, so that is FD3. Now talking about the ambulatory component, because most of R1 is inpatient, you do have some selectives that involve an ambulatory component. And then it's during these rotations, you're going to want to get 2 of these done, where you've seen a patient, but then you feel you need to refer them on to someone else. That's where you're going to have that consultation request letter and then get the person you're working with, the staff, to look over it and sign off on that. That's sort of the purpose behind that. If you don't have enough ambulatory exposure as an R1, this is something that may carry over into your core stage. But most all of the other EPAs really should be able to do. And again, I'd still get your allied health in hospital. That's harder to get outside of hospital. So now at some point during your residency, you will deal with unstable patients. And let me explain what unstable patient means to me. I'm talking about any time you're called to the ward for an acutely unwell patient. So chest pain, to me, I'd put that in the basket of unstable. You will see there's 7 successful observations are required. 3 are from the specific categories that I think are the same as transitions. So the acute respiratory distress patient, the altered level of consciousness patient, and hemodynamic instability. So you need these 3 signed off, and these 3 categories, each one needs to be signed off by a staff. Now, this is not direct observation where they saw you get called at 2 in the morning, but by review. So in the morning, you review with the staff. I got called by the nurses regarding Mrs. So-and-so who had acute chest pain. Here's what I did. Here's my note. They take a quick look and they can say, yeah, you did a really good job. Or maybe you did forget something. And that's the whole point of CBME, is to get this feedback. Okay. So now you've done a good job managing your patient. They've made it through to discharge, and they have the FD4 discharge EPA. Now, this has been divided into two. FD4A is the documentation of the discharge plan and meds, and FD4B is about communicating to the patient. So for FD4A, you need 2 successful observations where your staff, subspecialty fellow, or senior resident reviews your discharge documentation. I would argue that you should be writing out these medications for the EPA. I know we had a fantastic pharmacist on service last week who did all our meds, but to me that is part of the discharge work, and not all services will have pharmacists. So for this one, you really should have written the meds yourself, because you need to get that feedback. Was it clear what was going to be continued, what was new, what was changed? As you can see there, it's only 2 successful of these, and one of them has to be a complex stay, kind of greater than 72 hours, some complexity to it. FD4B is communicating to the patient the discharge plan. So sitting down saying, I just want to let you know we did hold your Coversil because your kidneys were a little irritated. We're going to get your blood work done in a week. I've already talked to your family physician, and he or she is going to look at that, and then they may ask you to restart your Coversil, but please don't start it until then. So having someone directly observe you have this conversation with them, again, staff, subspecialty fellow, or senior resident. Finally, the last EPA we haven't covered in foundations is FD7. Now this one isn't really at the end of a patient's journey, and this should be happening honestly every day. You should be reading around your patients every single day, and I don't mean spending hours and hours reading on everything on heart failure, but having a very focused question. An example with heart failure is, I have this patient with heart failure with reduced ejection fraction. They're on an ACE inhibitor and a beta blocker, but they're not on spironolactone, and I don't know when we're supposed to use it. So it's a very focused question. What are the indications for spironolactone in HFrEF? Okay? So that really, if you ask these good questions, it only takes you like 5 to 10 minutes to find the answer. What the Royal College is asking is that you should document this 12 times, and then the comps committee will look at 12 of these entries to decide if it's satisfactory. And these entries are found on assess.med, but they're under the assessments tab, not the evaluations tab. The way I think of the assessments tab is self-assessments and logs. Okay? So document those. These can literally be done every day for 2 weeks and you're done them. But obviously you should be doing them all the time, kind of documenting this. All right, so we've come to the end of foundations. I've covered the 7 EPAs with the multiple forms associated with them. I hope you found that helpful. If you did, please let me know at vdaniels@ualberta.ca. And if you did not, I'd still like to hear from you if there's anything I can change about this. Based on the feedback from your group, I am going to be creating another video for Core of Discipline to help the R2s and R3s. Thanks for watching.